Welcome back at Talk IC from Trieste, AICCER Congress 2025. We are with Professor Amar Agarwal from India. He's director of Dr. Agarwal Eye Clinics. There are 240 eye clinics in 10 countries, so congratulations for
Thank you
your
very much.
huge success and huge work. So today, can you tell us about these particular surgical techniques, the pinhole pupilloplasty, the fourth-row pupilloplasty, and the PDEC?
So basically the idea is this, Matthew. First of all, it's a pleasure to be here in this largest Italian conference in Italy, where there are about 2,000 delegates coming in to listen.
Yeah.
And I'm very honored to be one of the speakers here. When we talk of fourth-row pupilloplasty, it's a very simple technique which anybody can follow. So what you do is take a Proline needle, 9-0 or 10-0, pass it through clear cornea, through iris. From the other side, take a 26 or a 30 gauge needle through a paracentesis, railroad the two. Now you bring the single pass out, one loop out. Remember the number 4. Pass it 4 times, pull on both ends, and that iris is repaired. You don't need to do 3, 2, 2, etc. So anyone who has not done iris repair, please learn the single pass fourth-row pupilloplasty. Now, if by chance patients are there with high astigmatism, let's say RK post, ectasias, pellucid marginal degenerations, or anything with an injury, today we have started this technique called pinhole pupilloplasty. It's like the fourth-row pupilloplasty, but in which we are making the iris or the pupil like a pinhole 1.5 to 1 millimeter. There are many patients who come with corneal scars, injuries, even corneal opacities sometimes. In these, we normally do keratoplasty or eye transplantation. But today, with pinhole pupilloplasty, we can avoid keratoplasty. So in other words, I'm talking of pinhole pupilloplasty instead of keratoplasty. And the last point which I thought about, I'll talk to you is the technique called PDEK, or pre-Descemet's endothelial keratoplasty, which we started with Harminder Dua together from Nottingham, UK. And the idea in the PDEK is, it's an endothelial keratoplasty, but in which we are using the endothelium, the Descemet's, and the Dua's layer, total 25 microns. Why are we doing it? Because in PDEK, we can go even to infant donor corneas. In other words, the youngest I've used is a 9-month donor, which you cannot do in DMEC or in DSEC. The biggest advantage in PDEK is you will not get rebubblings. By and large, a percentage of rebubblings is about 1 to 3%. Whereas if you see in PubMed or peer review literature, you have rebubbling in DMEX about 20 to 30%. And the reason is very simple, because in the PDEK graft, the Descemet's is attached to the Dua's layer and cannot separate. So you are sticking a Dua to a Dua. In other words, it becomes an extended Dua, and that is why these patients with PDEK don't detach, and that's the success of this story. So basically, what I thought I'll cover today is on fourth-row pupilloplasty, pinhole pupilloplasty, and pre-Descemet's endothelial keratoplasty or PDEK. Thank you very much.
Thank you very much for your time.
Thank you so much.
Really, thank you.